Good afternoon. My name is Beth Faiman, and I'm joined by Dr. Joseph Tariman, Sandra Rome, and Kim Noonan, and we are here to discuss case studies for nurses, the evolution in myeloma treatment. This meeting space has been assigned to provide a symposium supported by the International Myeloma Foundation during the Oncology Nursing Society's 44th Annual Congress. The Oncology Nursing Society's assignment of meeting space does not imply product endorsement. The Annenberg Center for Health Sciences at Eisenhower is accredited as a provider of continuing nursing education, so don't forget to fill out your sheets at the end of the event to evaluate us, because you will receive a maximum of 1.5 contact hours earned for the successful completion of the activity. This slide here is a disclosure of conflicts of interest. It is the policy of Annenberg to disclose any conflicts of interest, and our conflicts of interest are printed in the bulletin. Print names, demographics, and identifying information on the case studies that will be presented have been masked to maintain HIPAA compliance. So there's no real persons have been used in the development of these case studies. Off-label use of drugs may also be discussed. Now, we have slides available for download at www.imfons.myeloma.org, as listed here. They may be live at this time, so you can check back during this presentation. Otherwise, feel free to go and download them after this symposium. Evaluations with CNE credit are enclosed in the packet along with the guidebook. So this packet is on the chair that you were sitting down on, so use those packets. As I mentioned before, my name is Beth Faiman. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. I'm joined by Dr. Joseph Tariman from DePaul University. Additional faculty are including Sandra Rome from Cedars-Sinai, right here in Cali, and Kim Noonan, who flew across the country from the Dana-Farber Cancer Institute. And Kim just acquired her doctorate of nursing practice, so let's congratulate Kim. We are all members of the International Myeloma Foundation Nurse Leadership Board. We are pleased to have other members of the Nurse Leadership Board in the audience that are enjoying this symposium today, as well as you are too. We want to thank you all in the audience, as well as our additional members, for joining us. The International Myeloma Foundation is dedicated in improving the quality of life of patients who are working towards the prevention of cure and prevention of myeloma. The International Myeloma Working Group, Black Swan Research Projects, as well as additional publications are all available at your fingertips at any time. You can go to www.myeloma.org, or actually we have a big packet of information available for you. You can see on this slide all these pictures of publications, CE credit, and I wanted to highlight this is our program brochure, which has our faculty information and disclosures, and on top is this is not a bottle opener, it's a fancy new key fob or USB point. I thought it would be a bottle opener. I said, thanks IMF for my new bottle opener. But it's actually a USB for you to download. And it takes hundreds of hours to compile all the guidelines for diagnosis and management of myeloma. The Nurse Leadership Board has published numerous peer-reviewed documents, as well as patient materials, patient tip sheets, side effect management, etc. So please do not throw these away or leave them in your hotel room. Take them home and share them with your friends. The agenda is listed on this slide here. We are going to be going through a series of case studies to highlight the importance of diagnosis and management of myeloma. And as a result of this program, you will be able to identify common treatment regimens in newly diagnosed multiple myeloma, discuss nursing management of myeloma patients receiving these newer therapies that are all available, identify the steps in shared decision-making. This is a big initiative, the Institute of Medicine, as well as other parts of oncology, and discuss the importance of survivorship care plans. On top of that packet that you have received is an ARS keypad. Part of our outcomes, we'd like to ask just a couple of pre and post questions. It's required for the symposium, and so if you don't mind taking a break from your salad, would you please answer the question, which of the following is used for diagnosis of myeloma-related organ dysfunction? 1, fluorescent in situ hybridization, or FISH. 2, monoclonal gammopathy of unknown significance, or MGUS. 3, spinal cord compression, albumin level, presence of lytic lesions, and total protein level, SALT. Or 4, calcium level, renal status, anemia, and bone lesions, CRAB. See lots of acronyms today. And we will be sharing the correct answers throughout the presentation, and then you'll have a post question as well. Next question, which element is essential to foster shared decision making? Greet your patient, seek your patient's participation, sharing information by both parties, or 4, building consensus about preferred treatment by both parties. After Dr. Tariman's presentation, you'll confidently pick the right answer. Now all of them sound good to me, right?
This will be an important take-home message.
Good. Number 3, which of the following is true about newly diagnosed patients with myeloma? Number 1, all patients should be tested for MRD as soon as possible. Number 2, shared decision-making is only effective if the doctor and patient discuss treatment options. 3, all patients need to be educated on many topics, including bone health, renal health, and infection prevention. Or 4, bone strengthening agents are only recommended for patients with bone damage from myeloma. And last but not least, which of the following is an all-oral regimen for relapsed multiple myeloma? Number 1, KRD, 2, IRD, 3, EPD, 4, DPD. And so this is the first day of Congress. Imagine how you're going to feel on the last day with all the disease states you're going to be reviewing. So at this time, again, I'd like to thank you for your kind participation. I hope you enjoy the program that we're beginning to deliver. And I would like to turn the podium over to Dr. Joseph Tariman, who will begin with the background of shared decision making.
All right, well, good afternoon, everyone. And I would like to only mention my manager, Paula Inches from Northwest Oncology Hematology is here, and my colleagues. I practice every Wednesday at Northwest Oncology Hematology. Thank you for coming, and welcome, everyone. Let's start with an overview of multiple myeloma. Multiple myeloma is a cancer of the plasma cells, and these 2 words are not common terminologies that patients often understand. We always have to go back to the basics, and we have to inform the patient that plasma cells originate from the B cells, and they are stimulated by an antigen. So when someone sneezes on you with an antigen, it will stimulate the body, the B cells particularly, to produce the plasma cells. And then the plasma cells will produce the immunoglobulins, the normal healthy immunoglobulins known as the GAMDE or GAMD. Myeloma cells, what happened in multiple myeloma is that because it is a monoclonal proliferation of plasma cells, it will only produce one type of the immunoglobulin. So instead of having a polyclonal response, multiple myeloma produces monoclonal response, and it's very typical that you will see in a multiple myeloma patient that one of these immunoglobulins are elevated. The most common multiple myeloma is the IgG, followed by IgA. So you will typically see an elevation of one of these immunoglobulins. And then, in part of the diagnostic workup for multiple myeloma, we are going to measure the level of the immunoglobulin that's produced by the multiple myeloma cells using serum protein electrophoresis for the heavy chain and urine electrophoresis for the light chain. Typically, if a patient has an IgG, the monoclonal protein will migrate in the gamma region, but for the IgA subtype, it will migrate into the beta region. So please pay attention to the laboratory result. This right now is showing that the protein is migrating into the beta region. This is typically seen in an IgA subtype. Whereas if the myeloma is an IgG subtype, you will typically see the spike happening in the gamma region, and that's your IgG multiple myeloma subtype.
In terms of multiple myeloma, not everybody with an abnormal paraprotein in their blood or urine actually needs treatment. So in my practice, I see patients with newly diagnosed extra protein in their blood or the urine. So they come to me thinking, what do I have? So I go through the different steps of diagnosis. So the first level is MGUS, monoclonal gammopathy of unknown significance. Those individuals have a little bit of extra paraprotein in the blood or urine. They may or may not have any anemia or kidney problems, but we definitely look for them to have a low amount of protein in the bone marrow plasma cells as well. If you go into the second level, is smoldering myeloma, where they have a higher paraprotein with an M spike about 1.5 to 2 grams, a little bit extra free light chain ratio. Again, when Dr. Tariman mentioned the M spike, there's also a serum free light chain where the light chains can fly off the immunoglobulin structure. And so in olden days, those used to be our non-secreting patients where they didn't make a lot of protein in the blood. So free light chain ratio is very important to the myeloma diagnosis as well when the light chains are high. Patients are catapulted into an active myeloma phase when they have a high amount of paraprotein in the blood or urine and they have CRAB criteria: hypercalcemia, renal insufficiency, anemia, or bone disease that can be attributed to the paraprotein. So as you can see, it's generally 3 levels, but within those levels, we looked at risks. So who's at high risk or low risk of needing treatment? The great thing about managing myeloma in this day and age is we have a number of excellent therapies. From 1960 to 2000, there wasn't much in the way of effective treatments. But since 2000, we've had an explosion of new therapies. We have classes of drugs: bortezomib, carfilzomib, and ixazomib. Those are your proteasome inhibitors. We have immunomodulatory drugs: lenalidomide, pomalidomide, and thalidomide. And then we also have monoclonal antibodies: daratumumab. Denosumab is a supportive care drug, but it's effective in decreasing skeletal events in patients with myeloma. So while many patients have this MGUS, they go about life with their normal health care conditions, and then ultimately something happens. The DNA in those cells change, and then it makes a clone of a normal protein, as Dr. Tariman mentioned. So that overproduction will lead to active myeloma. Some patients will live in that active myeloma phase. They'll go into remission. But unfortunately, through a series of remissions and relapses, they may ultimately become refractory as the clones will change over time. But the good news is that myeloma patients are living longer than ever. This is a study that looked at the different groups of patients from 2006, 2008, and 2010, and we saw a probability of living for over 8 years at least, if not longer. The good thing is now in the era of these newer agents, it's 2019, we don't know how long a newly diagnosed patient will live, likely for many, many years, as myeloma is turning to be a chronic condition.
And given the plethora of treatment for patients with multiple myeloma, as you can see, when I started practicing multiple myeloma way back in 2001, there were only a few treatments. Now we have over 15 novel agents now that we can use for patients with multiple myeloma. This gives us the perfect storm to really embrace patient-centered care, or what we call preference-sensitive treatment decision-making, using the shared decision-making model. The shared decision-making model is a healthcare delivery system model that includes the patient's preferences, values, and choices, putting the context of the patient into their lives while they are getting the treatment. It is very well aligned with the Institute of Medicine's guidance to improve healthcare and also their vision of the 21st century healthcare of the United States of America. And it's also embedded in the Affordable Health Care Act in 2010. So what is shared decision-making? Well, the definition of shared decision-making was really a breakthrough landmark publication by Whelan Gaffney, and they have defined shared decision-making having 4 elements. The first element is that it has 2 participants, the clinician and the patient. The second element is that both parties need to exchange information. And the third element is that both parties take steps to build a consensus. So this is an ongoing process. This is not static, and that this is really ongoing. And then the last step is that there will be a mutual agreement that will be reached between the clinician and the patient. This is the hardest part of the shared decision-making model. When it comes to the implementation of shared decision-making model, the mutual agreement should be explicit. A lot of times, this is implicit. We think that because the patient said, and then patients nod, that they already took the treatment and that's it. You go to the infusion center and you start your treatment. That needs to be more explicit, and one way of doing that is really to ask the patients, can you tell me more about what you understood about the treatment and when do you think you are going to start the treatment? Those are some kind of validation that we can really say we're able to have an explicit agreement of the treatment decisions. The Agency for Healthcare Research and Quality, AHRQ, also really tried to help a lot of the clinicians in the implementation of shared decision-making model by putting through the 5-step process called SHARE. In this process, what the Agency for Healthcare Research and Quality really emphasizes step number 1, and that is you need to seek your patient's participation. And how do we do this? Very simple. Right at the very beginning, we need to say to the patient, at this moment, your situation has 2 or more viable equal treatment options, and I would like you to participate in the treatment decision-making. Your preferences and your personal values matters the most at this moment. So this is very important, according to the Agency for Healthcare Research and Quality. After that, you can help your patient explore and compare treatment options. Make sure that you help the patient find the right information, guide them to the correct websites, give them some pamphlets from the International Myeloma Foundation, give them a lot of informations that are non-biased. And again, this is your way of making sure that the patient gets the information. Assess the patient's values and preferences. This is very important. What matters the most to the patient? Are they having an occasion? Are they gonna have a wedding? Are they going to have a graduation coming up? And are all these things that the patient's still trying to achieve embedded into the goals of the treatment? And then number 4 is to reach a decision with your patient. And lastly, always evaluate your patient's decision, because this is not a static process. This is always ongoing. You always need to revisit the decision of the patient. And here are some of the examples of what I call the clinical pearls that we can say to our patients. For example, for step 1, again, as I've mentioned, you need to explicitly say there are 2 or more treatment options for your condition. One is X and one is Y. And the benefit and the risk for X is this, and the benefit and risk for the Y is this. And how does that affect your situation? How would that affect your employment status? How would that affect the context of your day-to-day lives? The other exemplar is, hearing what I just told you, are there any thoughts, concerns, or worries that immediately come to mind? By saying this, immediately the patient may say, oh my God, I really can't do that because there's a wedding that's coming up, and if this treatment is going to require me to be in the clinic twice a week, that would be very disruptive to my schedule. So it's really important that the patient will provide their feedback immediately by asking them some of the feedback or immediate thoughts or concern as soon as the treatment is discussed. The word together is always a very powerful word that we can always share to our patient. Try to always use the word together in your conversation with your patient, just like this. We can make a decision together now, but you might also prefer to have some time to think about things or talk to others and make it on your own or with your family. This allows the patient what we call the option talk, which allows the patient to have a deliberation process and then make a follow-up appointment for the decision talk. And this is really important so that we can definitely have a very good implementation of what shared decision-making should be. So these are the 3 nursing role that we have identified in the literature in terms of what is it, if we delineate our role as nurses, what is it that we can do as nurses in the shared decision-making process? We thought that these 3 are the most important role. Number 1 is to empower the patient. And by saying there are many different ways to treat multiple myeloma, the doctor will be in shortly to discuss these with you, but since each of them have pros and cons, it is important to discuss what is important to you. if the patient asks you, if you are me, what would you do? The answer is always, I will always do what's best for me. So always give it back to the patient. Never, ever, ever go with the temptation that you're going to say something about yourself. Always empower the patient that it's about the patient. Inform the patient. Provide them with all the necessary pamphlets, educational booklets. You can also refer them to the NCI website. It has a lot of information. The NCCN website also have a lot of information about multiple myeloma and treatment options. And the third, but not the least, is to advocate for the patient. This is the third most important role that the nurse can do in shared decision-making. The exemplars that Mrs. Z said, she'd like some time to consider her options. Can I give her a myeloma booklet and schedule a return visit in a few days after she talks with her family? Or a statement something like this, Mrs. Z expressed concern about, is there something that we could do? So these are the kinds of exemplars that we can really show that we are advocating for the patient. That means we are putting our shoes in the patient's and we are doing the best that we can for the best decision for the patient. So this is the final slides that I'd like to share with you. It is important that patients and clinicians are educated about shared decision-making. This is a concept that's been around for quite some time, at least a decade. In fact, there's already a systematic review about shared decision-making. And that what we found from that systematic review was that it is important that we educate both the patient and the clinician on what shared decision-making is all about. My research is already completed, and we have developed successfully at DePaul the competency scale for the role of the nurse in shared decision-making, and it's going to be able to really identify the areas that needs to be strengthened when it comes to the competency of the nurse in shared decision-making. There's a lot more work to do, but never ever be paralyzed by all these limitations. Just move forward. Thank you.
You're not done yet. Stay up there. I still have more slides. Dr. Tariman is so passionate about his research, and that's why we put it in the beginning, because it's so important to our myeloma patients. In many cases, as I mentioned, there are different levels. And that smoldering level, people that don't quite have myeloma yet, we have to find ways to treat them before they have organ damage. Options for high-risk smoldering myeloma, those ones that we can predict might need treatment in the next 1 to 2 years based on bone marrow plasma cells, PET or CT scans, those are ones that need a lot of our guidance and counseling. The International Myeloma Foundation has a lot of information. There are 4 major phase 2 clinical trials. 3 of them have lenalidomide as a backbone, which is a pill. And each of these clinical trials with ixazomib Lendex, elotuzumab Lendex, carfilzomib Lendex, and just plain old daratumumab, each of these show that it might be beneficial to patients to start treating later. Updates as smoldering treatment paradigms are evolving, but this might be something we are going to be talking more about. If you have a patient in your clinic that has a lot of protein in their blood or urine and they're not quite fitting that CRAB criteria requiring treatment, direct them to the myeloma.org website. They have a myeloma matrix that outlines clinical trials that are open in their area. They have an IMF info line at 800-452-CURE, and you can direct them there for more resources.